So we will be taking up some of the questions. I start with some of the questions from my side, and then we will be taking up question from the audience. I think Dr. Umesh showed a very important slide that 1/4 or 1/3 will be organic dyspepsia, and then possibly 2/4 or 3/4 will be functional dyspepsia. The issue is that most of the guidelines, they say that limited workup should be done. If we work up for, say, for gastroparesis or motility disturbance, what type of test? Scintigraphic, we go for liquid gastric emptying, we go for solid gastric emptying. And what are the subset of patients we take up for small bowel transit time studies or full intestinal transit time studies? So like the case which Dr. Goyal was trying to show, this is the perfect scenario where, to my mind, is possibly the ripe case to assess for gastric emptying as well as the small bowel transit time. So should we be doing in most of the patients, selective patient, and if we selectively, then how we go about? The Fortunately, both our speakers are from North India, and alcohol remains a very, very important problem in North India, also in South India, but more in, I believe, more in North India and Punjab, in particular. Dr. Umesh and I, we are at the receiving end. So, what is the role of alcohol? That has not been touched upon. So, in dyspepsia, and this one very important question, like deprescribing. Now people are talking so much about deprescribing PPI or PCAB. So in functional dyspepsia, how we deprescribe PPI, how we describe PCAB, and when we are using PPI with prokinetic or PPI or PCAB along with levosulfuride or for that matter ecosamiide, which one we will step down first? We will switch off the ecosamiide first, or we will switch off the PPI first? Is there any information in literature or there is any clarity in studies? So that will be very important. And EGG is not widely available as of now in India, but few centers, they are doing it, and they are reporting pretty high frequency of positive studies. So what is the current status of EGG in evaluation of dyspepsia? So Dr. Umesh and
So very pertinent and clinically relevant questions that you have posed, and which do not have any perfect answers as per now. So, but I will try to handle those related to diagnosis part, and Srihari will take up those related to treatment part. So, as Dr. Sinha sir said, so it is always dilemma in a clinician's mind when such patients came, maybe with chronic diarrhea, chronic constipation, or dyspepsia, how much to investigate. So, I mean, as per the Rome criteria, they are very clear that for dyspepsia, yes, that for to label as functional, you need at least upper GI endoscopy and H. pylori testing. Obviously, the routine test, like we suppose a random blood sugar, a complete blood count, a thyroid renal function test, this we know that all patients are carrying with themselves, and they believe that these tests are normal. But yes, the message should not go that we should get an endoscopy in everyone. So I will start from the beginning. The patient comes with dyspepsia, basic test normal, no alarm features, start empirical therapy, no need of upper GI endoscopy. If you have facility available for non-invasive H. pylori testing, like a breath test or a stool antigen, you can get it done. You can treat, but again, as Dr. Srihari discussed, India is so prevalent, we might or might not do that. If there are no alarm symptoms, then we can even go without that. Start empirical treatment according to the type of dyspepsia. Treatment was discussed by Dr. Srihari. EPS symptom predominant, we treat with PPIs. And PDS symptom predominant, we start with prokinetics. As per the Rome 4, they're very clear. And then we can add these two drugs, vice versa, in both the groups if the response is not there. Still not responsive. The correct timeline is not there, but at least I would say 8 to 12 weeks, no response to symptoms, get upper GI endoscopy. First to rule out organic cause of dyspepsia. Then the next step of investigation, if upper GI is normal, again, I think we should still give a pause. We should take a proper psychological history, because most of the patients, they have psychological issues rather than some organic issue being missed. Although I think both the things we have to keep in mind. As Dr. Srihari rightly said, we rethink whether we are missing some organic disorder, and number two, we assess for psychological more finely. So if we have some anxiety, depression, or psychological problem, we treat that as this drug therapy. We discuss tricyclic antidepressants, other drugs. We treat that. But if the patient clearly denies no psychological issues and psychological evaluation is normal, then it's a time to rethink for other organic disorders being missed. Again, Dr. Srihari, a very beautiful slide. The patient had predominant bloating, think of concomitant IBS, think of overlap syndrome. Patient has predominant early satiety, predominant nausea, vomiting, think of gastroparesis. So I think the next step of evaluation, which all tests for these are not available at periphery, then the patient should be referred to a tertiary care center. And depending on the predominant symptoms, EGG or scintigraphy in patients who have persistent nausea, vomiting, PDS, we should do that. Test for gastric accommodation, gastric emptying. The patients who have more of bloating or stool symptom, we treat for IBS. So the next step should be symptom directed and as per the availability of the tests.
Professor Sinha asked about the EGG that has been routinely
Yeah,
been done.
yeah.
I think the EGG that is available now, right now, sir, in the market, to be very frank, this EGG has been available since at least last 30-40 years in the West. But it didn't take off significantly because it is still not proven to be very, reliable or very specific. I think you need a more an EGG which has much more sensors which can pick up the gastric activity. As of now, whatever we have is 3 or 4 sensors. I really doubt how efficient this machine is. I am not sure Dr. Umesh Goel will agree to this, but I'm not still sure how efficient this machine is to actually pick up patients with gastroparesis. So far, whatever literature states, I think it is still your gastric scintigraphy is still which is the considered as the test of choice or the gold standard to diagnose gastroparesis. I don't think we can rely on EGG so far with the available test that is there in the market.
Yeah, very rightly said. But I think the
What sort of scintigraphy you go for? You go for liquid scintigraphy or you go for solid mill scintigraphy?
Solid mill scintigraphy. Usually, solid mill scintigraphy is the one that is done in most of the centers.
I would like to add here is, I think the apparatus which we have, it has 8 to 10 sensors, number one. Number two, scintigraphy will just tell the delayed gastric emptying. That's right. This first line of test should be scintigraphy to document whether the emptying is delayed or not. But EGG, now we had good number of around 8 to 10% cases who had APDO, enteropyloric duodenal obstruction, which EGG will not tell. And those patients have normal gastric motility. They have APDO, and we used pyloric directed treatment. We did GPOMs in one. We did pyloric dilatations in people who could not afford GPOM, and we had gratifying results. So in this sense, I feel EGG is a good add-on to scintigraphy in patients who have delayed emptying. Obviously, we don't do it simultaneously. There's a delayed gastric emptying, patient is a diabetic, all setting is here, you treat for gastroparesis. Think of a poor myoelectrical activity. But we had few patients who were non-diabetics, no comorbidity, who had delayed gastric emptying, and EGG showed APDO, and we treated that with good results. So that should be used in selective cases.
Right.
So, but if we see the guidelines, most of the guidelines do not give much wide space to EGG.
Because the data is not much right now, but as data will emerge, I think this might be more important to use.
So, clarity will come with that.
Yes.
Slightly more difficult issue which I'm going to raise, but maybe a practical issue, is the deprescribing.
Yeah, Dr. Srihari.
Which one you stop first? You stop ecosamiide first, or you stop PPI first, or you decrease the dose simultaneously? How should we go about it? Is there any information in literature on that front?
I don't think there are any guidelines on to this regard, but I think deprescribing would depend on the morphology of dyspepsia that you have. Suppose you have a epigastric pain syndrome kind of dyspepsia, the PPIs are the more useful drugs in such a case. So here, de-prescribing, if you are using already a combination of a prokinetic and a PPI, I would like to de-prescribe the prokinetic first and then go on to the PPIs. PPIs I would like to run for a little longer than the this thing. If it's a postprandial distress kind of a dyspepsia, so here I would like to take the prokinetics for a longer period of time, de-prescribe the PPIs first. The duration, obviously, I don't think is there is clear cut this thing to that, but I think we can take a corollary out of GRD treatment. In GRD, even you have patients with chronic GRD, but you don't always try to keep the patient on the same doses. You run the same dose, the prescribed dose of the standard dose PPI for 8 to 12 weeks. If the patient is doing well, you start tailoring the doses. If the patient has been twice daily PPI, you reduce it to once a day. If the patient is on once a day, you try to put him on alternate day and see if the patient is responding. If the patient is responding, you can go on tapering the doses further and eventually try to stop it. I think the bigger thing is 8 to 12 weeks of treatment, and then you try and taper and see what happens. If the patient is doing well, we should eventually try and stop treatment in all such patients.
And extension of the same question. Do you ever use, I'm talking not at the tapering phase or de-prescribing phase, I'm talking of the beginning. Do you ever use prokinetic as a sole agent for treatment? And what the guideline says. The second part is that if we use for longer period the prokinetic, does the use become off-label use? Will it be considered for legal purposes off-label use?
So I think that's a very relevant question, sir. Apart from guidelines, what usually is practiced, you see, most of these prokinetics have come up with a combination with PPIs. So I think we are all guilty of that. We always give a combination of a PPI and
I
a
think,
prokinetic in general.
fortunately, ecosamiide at the moment,
Yes.
none.
So usually the practice is most of the people would be given an etopride or a domperidone combination along with a PPI to start off with. Actually, these are not, scientific combinations. They should not be actually available, but that is how, the pharmaceutical market is there in India. People are very, they are amazed if they are given in a combination. They feel that's a much more stronger agent as compared to PPI alone. So they should be used individually. I think, yes, individually prokinetics do have a role. You don't always have to add a PPI. Like if it's a postprandial distress kind of a patient, an individual prokinetic might be as good as an agent to treat this patient. How long can you use it? I'm not sure if there are guidelines to this, but I think most of the studies that we have are around a year or so. So I think 1 year should be the right time to reconsider whether you need to continue, and if you need to continue, how long. Yes, we do have safer prokinetics like acostamide, etopride are fairly safe prokinetics which are available. I would not be very comfortable using a levosulpride for long. In fact, I'm not at all comfortable using levosulpride in a lot of patients, especially the elderly people. That is one of the things I'll be very, very careful about when you use it in most of the patients.
I think I agree with Dr. Srihari, and I think the tapering of this is again not in guidelines, but has been discussed in expert consensus meetings that again you can decrease it like doses to half and then 1/3 and then stop, rather than suddenly stopping. Suppose we're using etopride 50 mg thrice a day, we use it to but BD and then OD dose and then you can stop. Again, not in guidelines, but this is the practice which can be followed to gradually stop.
Any comment queries from the audience organizing team? Lupin team?
Yes, sir. We have received the questions from the audience. If you
So
want, then I can read the questions for you.
Yeah, no.
for the
I think
you
in
can
the
take up
WhatsApp
two
group,
questions.
in the WhatsApp group, there's a question I can answer this. Dr. Gagan from Delhi has asked how a physician can differentiate between PDS and EPS clinically. So I think the clear-cut answer to this is 4 symptoms should be asked: epigastric pain, epigastric burning. If they are the predominant symptoms, this patient has EPS. This patient needs PPIs. If the patient has symptoms related to meal, that is postprandial fullness, early satiety, and inability to complete the normal meal, the patient has PDS, and he will benefit more from prokinetics. Maybe a simple acostamide can help, no PPI required. But 20 to 30% patients can have overlap also, can have both symptoms, EPS and PDS both. In this, we use a combination of PPS and prokinetics as per the guidelines. The next question which I can find here is most of the patient practice want sudden relief from symptoms of FD. So how to start prokinetics and which is the best reference? Dr. Srihari.
So I think it is more about reassurance that it is just functional dyspepsia. Everybody would want sudden relief from almost everything, but that might not always be possible. I think reassurance is what helps. But yes, prokinetics, if you think of it, in my preference, I think the two very good prokinetics that are available, one is ecoshiamide and the second is etopride. Ecoshiamide, you start 100 milligrams 3 times a day, and etopride you start 50 milligrams 3 times a day, both of them before meals. So best preference, I think it is up to you to decide, but I think in general these are the two good available safe prokinetics that are there right now in the market, especially for upper GI symptoms. For lower GI, I think prucalopride is one of the options that you have.
Sinasa.
Prior to availability of ecosamiide, we are very extensively using etopride.
Yes.
And we had life-threatening arrhythmias in 3 patients. No way we could confirm that this was related to ecosamiide. But 3 life-threatening arrhythmias we documented in hospital when we didn't get any other cause. So this remains conjectural. This will not be taken as scientific evidence. After that, we became little cautious in use of etopride, but the same problem we have not observed with ecosamiide till now. I don't see, we live to learn. But how happy are you about the H. pylori story? In Cochrane review, it looks like an open onset case. But if you go into detail, the difference between the eradication and the benefit part is just around delta is approximately 10 to 20% only. It is not a great delta that it makes a difference of 60%, 70%, that type of thing. And then issue arises when we are treating the patient is with me long term. It is not that patient is with me for 3 months or 2 months, 6 months, and that is end of the story. Patient keeps following years and years after that. So after eradication, when I need to retest, is there any information available?
So I agree, sir. That's a very relevant point. H. pylori is still an enigma, I think, in the Indian setting. I think most of these guidelines come from the West, where a very small proportion of the people would be affected by H. pylori, and eradicating H. pylori in them looks practical and maybe offers you greater advantage. But in a country like ours, where H. pylori is so substantially common, and also there's so much of drug resistance, we really don't know whether the medicines that we are giving, because I don't think anybody of us goes and tests back whether there has been eradication. Because for eradication also, you need to test this patient after 4 weeks of treatment, not immediately.
That is not that. I was not talking of that. I was talking about in the context of dyspepsia. Like, understand, the delta is just 20% max.
I agree, but it's a proven class 1 agent. I mean, it's a proven treatment for H. pylori.
What you do, like somebody has got eradicated, there will be always issue of reinfection in India. Okay, so West says reinfection rate is 1 to 2% per annum. In India, it is upward of 10%. Okay. And this issue, I'm aware. I'm like ISG has its own published its guideline. I was a member of that guideline, and we are on the threshold of revising that guideline. But that information, I think, to my mind, it looks like that we will not be addressing that much for want of evidence. But in the dyspepsia setting, there is most of the guideline remains silent when we should be retesting, not to check for eradication, but in the context of persistent symptoms of dyspepsia.
So I think, sir, if we have tested and the H. pylori is positive and the patient has come with dyspepsia, you have to go ahead and treat him. Either you don't test at all, or if you have tested and the patient is positive, if you don't treat, I think you're not doing the right thing. You'll have to treat these patients.
That's okay. But because delta is only 20, So what is ultimately you get? You get almost 2/3, 3/4 patient who will continue to have symptoms.
Agree.
So what do you do with them? Will you test H. pylori again? Eradication confirmed. For reinfection, recurrence, when to test?
So if I have tested and the patient is positive, I will treat. For eradication, I will test after 1 month. For retesting, I will test after 6 months.
Does any guideline mention that?
I don't think so, sir. I
I
mean,
don't think so.
I
So
don't-
this will be individual opinion by experience.
yes.
So, okay. Dr. Goel, you will go by 6 months theory?
Yeah, I think as until there are no guidelines, you can test after 6 months. There's no practical thing we can follow.
Okay.
I think
Any more audience question we need to take, or we just close?
so. You can give the concluding remarks, sir.
I think we had a very good discussion, and very clear algorithm were shown, and very clear algorithm for the treatment was also shown, and I think lots of issues were discussed and clarified that what should be done. I thank the organizers for organizing this conference, and I hand over the proceedings to the organizers.